Hello, everyone. Welcome to our fourth and final lecture on arrhythmias. This time we'll be reviewing arrhythmia pathophysiology, just the very basics. I will preface all of this by saying that you do not have to know everything incredibly in depth, but this is just to give you a general understanding of what causes these arrhythmias and how certain treatments could work for specific types of arrhythmia. Before we start talking about any specific arrhythmia, let's take a look at some of the pathophysiology that can predispose a patient to a specific type of arrhythmia. We'll first start with our tachyarrhythmias. And tachyarrhythmias are any rhythm or rate issue where the rate is greater than 100 beats per minute. The three main causes of tachyarrhythmias, or underlying pathophysiology of tachyarrhythmia, are automaticity, triggered activity, and finally reentry. Let's first take a look at automaticity. Tachyarrhythmias caused by issues with automaticity tend to arise here. We have our brain, and this nerve fiber here, or this series of nerve fibers, is our sympathetic nervous system. As we've alluded to before, the sympathetic nervous system will go and it will release norepinephrine and epinephrine onto the SA node and the AV node, increasing the heart rate and increasing the conduction velocity through the AV node. Causes of this increased sympathetic outflow are really anything that you would think could normally increase the heart rate. So a lot of these are going to be things that put extra strain on the heart or things that cause the heart to try to compensate for issues in oxygen delivery to different tissues. Some of these, this is not comprehensive, but can include hypovolemia, low blood pressure, of course. We could do hypoxia. This can be due to any issues getting oxygen into the lungs, any issues with oxygen being able to be carried in the blood, etc. Some other causes, as we saw over here, as norepinephrine and epinephrine are going to increase the heart rate and increase this sympathetic outflow. Anything else that is a sympathomimetic can also cause this tachycardia. Pain can cause increased sympathetic outflow. Anxiety can also stimulate this outflow. And finally, the other one I want you to remember is hyperthyroidism. Overall, these are things that you should be familiar with. This should make sense when you're thinking about it as you see these symptoms arise from other disease states, but just realize that anything here that puts a stress on the body or increases the body's oxygen demands is going to stimulate the sympathetic nervous system to then cause increase in heart rate just to try to supply the body with the blood and oxygen that it needs. Our next cause of tachyarrhythmias can be from triggered activity. And as you can see here, triggered activity can be broken down into two subsections: early after depolarizations and delayed after depolarizations. Let's start with early after depolarization. So as this is written in this purple color, this relates back to our last lecture on the antiarrhythmic drugs. And I want you to remember this purple, was potassium channels. And this was associated with that arrhythmia that we mentioned many times last lecture, torsades de pointes. So what is really happening in early after depolarization? The main thing you should be aware of with early after depolarization is it is mainly seen or more commonly seen in patients that do have, for some reason, whether it's drug-induced or physiologic, some sort of QT prolongation. Now, as we remember from our last lectures, depolarization here in the cardiac action potential, usually done by sodium here at the beginning of the action potential, will then lead to the opening of voltage-gated calcium channels. And calcium channels are what are going to cause this plateau phase and the contraction of the cardiac myocyte. So if our QT interval is prolonged, especially, the longer that those calcium channels are allowed to remain open, and the longer that the cell is kept above the potential for the calcium channels to remain open, we can start to see an influx that is pathologic right around this area, either during the early repolarization phase or kind of during this plateau phase, a pathologic reactivation of those calcium channels that causes another pathologic depolarization. And this can happen over and over and over and over again. And as you can see here, this rapid depolarization can lead to very, very, very fast ventricular rates. And this is very commonly associated with that fatal arrhythmia we talked about many times, torsades de pointes. So just as a brief review, the calcium that we normally see, which is responsible for this plateau phase and the contraction of the cardiac muscles, when the QT interval is prolonged, I would essentially think of it in a very simple way as the calcium channels become confused. Normally the cell is supposed to have calcium influx, and then potassium channels being responsible for repolarization will then cause the calcium channels to close back up. If you have this interval prolonged, I would think of it very simply as calcium channels become very confused, and they think that because there is depolarization, that they should activate again, thus causing calcium to rush back into the cell in this almost confusing cycle for the ion channel, causing these early after depolarizations. Now on to delayed after depolarizations. We'll start off by talking about a couple of common arrhythmias that can be associated with this, and you do not have to remember all of these. One that I would make sure that you're at least somewhat familiar with is that premature ventricular contractions are definitely associated with, to some extent, with delayed after depolarizations. Now, these can be something that is concerning, especially if a patient has structural heart disease, but in the absence of structural heart disease, and if these are not causing too much of a physiologic issue, they're not too great of a concern. You can also see with these multifocal atrial tachycardia, and also the big one that I do want you to remember is ventricular tachycardia. Delayed after depolarizations are slightly less well characterized, but the main thing I want you to understand here is this stems from some sort of issue with the handling, the intracellular handling of calcium. But I want you to think about this as if you have a lot of calcium in the cell. That could be in the sarcoplasmic reticulum, sorry. And if that happens, you risk the calcium starting to leak out. And through some ion channels, that calcium leak, that extra calcium that is not being handled properly inside the cell, can cause an influx of sodium, thus causing a pathological depolarization. And we will normally see these actually a little bit later in the action potential, so not quite as early as the early after depolarizations, but we'll see them a little bit in this more repolarized state, or sometimes in this nearly fully repolarized state in the stage 4. So your delayed after depolarizations will look a little bit more like this. For example, so they happen a little bit later than the early after depolarizations, but they're still, as we see here, earlier than the normal next action potential would be. These are both the, this is a synopsis, I should say, of the overall pathophysiology of triggered activity. And our final possible mechanism for tachyarrhythmias is re-entry. This one I absolutely do want you to please be familiar with, as it evidence does indicate that re-entry is responsible for the large majority of clinically significant cardiac arrhythmias. So be familiar with the mechanism on how it works. I will note that sometimes we're not totally sure if some of these arrhythmias are maybe caused by a combination of triggered activity and reentry, but I really do want you to recognize that reentry is a very important mechanism for cardiac arrhythmias. Let's first look how conduction is supposed to go through one of these loops that we see with reentry loops. So the first thing to note with reentry is that you do have some sort of bifurcation, some sort of loop that is present in the cardiac conducting tissue. This can either be within a node itself, such as the AV node over here can have this type of loop present in it. This can be within the bundle of His. This can be within the Purkinje fibers themselves, bundle branches. It can really occur at any part in the cardiac conduction system, but the presence of this loop is important for reentry. Under normal physiological conditions, a signal will come down. Let's say that we're looking at some sort of cell that is over here in the ventricles. So we'll highlight that in green. Let's say that we're looking at cells right down here in the ventricles. So here we have a signal coming down. It will have come, of course, from the AV node through the rest of our normal conduction system, through the Purkinje fibers, and it's reached this point where the signal can now bifurcate down two different pathways. We'll see it go down the left and down the right. Under normal conditions, the signal would then shoot off into the other areas of the cardiac conduction system, and each of these signals from each branch would then try to continue down this middle path. And you definitely do not need to go back and review physics, but two waves of equal amplitude will cancel each other out. So under normal conditions, this cycle will continue. Signals will bifurcate, go to the rest of the cardiac tissues, and cancel each other out in the middle. Nothing is wrong in a normal tissue. However, let's consider that maybe our patient has had, maybe they're a bit older, or maybe they've had some sort of cardiac history wherein the cardiac tissue is a little damaged, it's a little bit scarred. So not all of the tissue is working properly. As we see here, now we have some damaged tissue or some scar tissue on the left side of this circuit. So as the signal comes down, it will then again try to bifurcate into the two branches of the circuit. On the right-hand side, it will continue much how it has before, shoot off into the rest of the conduction system, and curve back into this middle connection. But on this left-hand side, due to the scarring, the signal is drastically slowed. You can almost imagine it as bouncing off all of these little jagged edges. So it takes much, much longer to try to get through here. And in that amount of time, this bottom signal here that normally would get canceled out in the middle will actually have time to travel up and block this signal from actually getting through. So as we see, during this first action potential to come through, the rest of the cardiac tissue will receive a regular stimulus to both sides, and the signal just coming down this left branch will be blocked. The next piece of information that is crucial for the next part of reentry circuits is that in this left branch, in this fibrotic branch where the conduction is slowed down this side, when we see a decrease in conduction, we're actually going to see an increase or a shortening of the refractory period. What does this look like? At this point, let's say that maybe there's signals are coming through fast. Maybe it's a higher heart rate, or for some reason there is a new extra signal. We could look back at our triggered activity and say maybe it's a delayed after depolarization or an early after depolarization, but some sort of early signal comes back down into this tissue. And when it gets here, the right-hand branch, as the conduction was faster, so it's the opposite of this, conduction was faster in the right-hand branch, so it has a longer refractory period. So the right-hand branch is still refractory. So as the signal tries to come here, it actually is going to get blocked trying to go down the refractory branch. The signal will then travel down the left branch, which, as we said, lower, slower conduction is a shortening of the refractory period. So this branch can actually conduct the signal already. So we're going to see the signal, albeit slowly, travel through this left branch, stimulate the rest of the cardiac conduction system, and similar to how we saw before, it's actually going to loop back over to this side of the reentry circuit. At this point, maybe by this point, the right-hand branch has actually started to come out of its refractory period. It's actually able to be stimulated again. So now we see no more refractory on the right-hand branch, and this is happening at a specific timing when the signal that has traveled through the left branch of the reentry circuit is actually able to come back up the right branch of the reentry circuit. And this, as you can see, can be very problematic, as it will come back up the right branch, fire a signal back up to the atrium, and then continue back down this left branch of the reentry circuit, as it is most likely already out of its refractory period due to that refractory period being short. This cycle will continue over and over, with the signal traveling through the slow conduction tissue, looping back around. As the right-hand branch is no longer refractory, it can travel back up it, send a signal up to the atrium, travel back down this left branch, around, up, signal to the atrium, and this can continue in this circuit. As you can imagine, this can produce some very, very fast heart rates, as the signal is not having to be produced by any sort of like the sinoatrial node or the SA node. This is just running essentially rampant through this circuit over and over again. If we look over here on the right, on the heart, let's say that this little area is that circuit on the left that we have just talked about. So essentially, this process has created this little loop here that is continuously sending signals to the ventricles and up and depolarizing them, creating very fast ventricular rates here. And this can be an example, if it is sustained continuously, of, like we said earlier, VTach. Or if it's not sustained indefinitely, this could just be a premature ventricular contraction. Now, it's important to note that, as we talked about here on the left, there are a lot of things that have to line up timing-wise fairly exactly. So a thing to remember with reentry is that it is incredibly timing dependent. And this is true both for the pathogenesis of a reentry circuit and also any sort of signal that can come in and stop this reentry circuit. For example, if you did have at an exact right time a signal get through from the SA or AV node and travel down and actually cause some of this tissue to be refractory when normally the signal would come back up through it, then you could actually stop this circuit from happening. So, important thing to remember, this goes both ways. Perfect timing or very circumstantial timing can cause reentry circuits, and it can also stop reentry circuits. Now, looking back at tachyarrhythmias, we have two subsets. We have supraventricular and ventricular tachyarrhythmias. Let's first take a look at the supraventricular. As denoted by the name, these supraventricular tachyarrhythmias are going to happen in areas, or originate, I should say, in areas above the ventricles. So that's going to be on our little heart over here, right up here, somewhere within the atria. Now we'll go over a few common supraventricular tachycardias and just a super basic version of their pathophysiology. So the first one that we're going to talk about relates back to the automaticity that we talked about before. So let's say that in this first one, we have increased norepinephrine that is coming down and binding to this SA node, increasing the heart rate and increasing conduction through the AV node. That would just simply be called sinus tachycardia. If all of the rest of the heart rhythm is normal and we just have an increase in the activity of the SA node and conduction through the AV node, we'll just call that sinus tachycardia, heart rate greater than 100 beats per minute. Let's say now in one of the atria up here in the top chambers of the heart, let's say we have another irritable area. And now it doesn't matter whether this is a reentrant circuit or some sort of after depolarization. You can think of it as a reentrant circuit, but let's say we have just one little area of the heart tissue up here that maybe it's been stretched or damaged and it's firing off action potentials that it normally should not. If that rate, of course, supersedes the SA nodes rate, which often they can, then that will produce a tachyarrhythmia. And if it's just one little spot here that's producing these rhythm issues, that would be called focal atrial tachycardia. The next one is fairly self-explanatory. Let's say instead of just the one little irritated area, the little ectopic focus, let's say we have maybe 3 or 4 little irritated areas. And all of these little irritated areas are firing off signals through the atria. That would be called, very simply, multifocal atrial tachycardia. One thing to note with this is that it is harder to recognize this on an EKG. It does require the presence of 3 morphologically distinct P waves. You don't have to focus on all of that, but just realize that multifocal atrial tachycardia is just multiple of these ectopic foci. This next one I definitely want you to remember. Actually, the next 2 I definitely want you to remember, as they are some of the most common arrhythmias that we see in practice, are atrial flutter and atrial fibrillation. So starting with atrial flutter, usually it starts with some sort of irritation in this area, more specifically, usually on the right side of the heart. That is then with some sort of loop or depolarization, firing off action potentials to the rest of the atria and to the AV node. And this is called atrial flutter. And atrial fibrillation, you could have dozens of little spots in the atria that are all these little irritated ectopic foci, and these are all individually firing off into the atrium in a very chaotic and disorganized manner, as you see here. And this ultra disorganized manner and all of this different firing essentially leads the atria to quiver in place. So in atrial fibrillation, we'll see the atria are kind of just quivering. They're not actually fully beating in any pattern, just quivering very rapidly. And this is, as we just mentioned, called atrial fibrillation. Our next supraventricular arrhythmia is actually going to arise here in the AV node itself. So as we talked about, this is a reentrant circuit. This one is well documented to be a reentrant circuit, and it is within the tissue of the AV node itself. So we have this reentrant circuit that is constantly shooting off electrical potentials down to the ventricles, up to the atria, at those very high rates. And when this is happening in the AV node itself here, we call that AV nodal reentry tachycardia. And our last type of supraventricular arrhythmia is a little bit of a weird one. So it's usually associated with some sort of congenital issue with how the heart is set up. So a common one that you will hear of is Wolff-Parkinson's White syndrome. All you have to know about this is there is some sort of, as we see over here on the right side of the heart, or actually the left side of the heart, right side of our screen, sorry, we see some sort of abnormal conduction pathway where signals can actually come to and from the atria. So it can go from the atria to the ventricles or from the ventricles to the atria. Now, this is something that is pathologic, of course, not generally found in most individuals, but especially in people with Wolff-Parkinson's White syndrome, there's this abnormal connection of conductive tissue between the atria and the ventricle. The more common version of this arrhythmia that arises is we will actually see a signal that is sent from the AV node, or sorry, from the SA node to the AV node through our normal cardiac conduction system. We'll see it would normally bifurcate here, But the signal is then actually able to come up the ventricles through this abnormal circuitry and stimulate the AV node again. And this creates a type of reentry loop that keeps circling and circling and circling. This can get you to some, of course, very, very fast rates. And it's the reentry up here in this abnormal connective tissue is not regulated on how it is through the AV node. This is the more common version of it. This is an AVRT. More specifically, this one is orthodromic, sorry. AVRT. And there is, interestingly, a version of this that is different. It's much, much less common, but much, much more deadly. That is called antidromic. AVRT. And I want you to, for this next explanation, pay attention to the anti. Our antidromic AVRT is going to have actually the opposite cycle of the orthodromic. So instead of coming from the SA node and going to the AV node, the signal's actually first, for some reason, whether this be due to an AV node block or slowed conduction through it, the signal is going to choose to not go through the AV node, and as it will have less resistance, it'll actually come down this abnormal circuitry and come down to depolarize the ventricles. This is, of course, very dangerous, as this abnormal connective tissue is not regulatory how the AV node is. It will not slow down that signal. It will not hold on to it. So this type of antidromic AVRT, I'm sure you can appreciate, can be very deadly, as there is little to no regulation on the rate of this type of arrhythmia. Of course, it will then come back up the Purkinje fibers, the bundle of His, into the AV node, and then, of course, we'll continue this same cycle back through and around as we saw with the orthodromic. This can be especially deadly if your patient also has atrial fibrillation, because at that point you can have atrial rates in the hundreds of beats per minute, and all of those can be conducted down into the ventricles, thus causing ventricular fibrillation, which, if not resolved incredibly rapidly, is deadly. The next type of tachyarrhythmia are our ventricular arrhythmias, and as we would assume, these are going to originate down here in the ventricles as opposed to our supraventricular tachyarrhythmias. The first one is ventricular tachycardia, and this can be caused, or this can present multiple different ways. You can either have a monomorphic ventricular tachycardia, and this is usually caused by one of those ectopic foci or one of those irritable areas down here, whether it be through delayed after depolarizations or reentry circuits. This is firing off pretty rapidly into the surrounding tissue. And this is called ventricular tachycardia. And these can be caused by both triggered activity, particularly delayed after depolarizations, as well as reentry circuits. And then, pretty similar to what we saw in the atria, if we have multiple different spots in the ventricles that are all firing off abnormally for whatever reason, that would be called that would present as a polymorphic VTAC, and this is particularly if it is a normal QT interval. The next one that we're finally going to talk about is a big one that you absolutely should and do have to remember, is our torsades de pointes. And as we remember, this is caused by early after depolarizations. And it is associated, or I should say it is classified as a polymorphic VTAC with prolonged QT interval. Something that I really want you to remember for torsades de pointes is that it is, of course, as it is caused by this prolonged QT interval, anything that is going to affect the rate of repolarization or affect the amount of time that a cell is refractory can contribute to the QT prolongation, and torsades, this arrhythmia. Something important to note, as we kind of alluded to with the reentry circuits section, is that not all tissues in the heart are created equal. Not all tissues will be perfectly refractory the same amount of time, etc. And we're not totally sure the exact way in which one section of early after depolarizations ends up affecting the entire heart and torsades, but it's thought that many different areas that become refractory for different periods of time, there's this dispersion of refractoriness. In addition to these early after depolarizations causes this very essentially chaotic sort of depolarization. And it will actually present with an EKG, we'll write above the heart. The EKG, it's called torsades des points, or twisting of the points, because if we were to draw an axis down the middle of the EKG, this arrhythmia is actually going to look a little bit like this. Almost as if we have a ribbon that is being twisted around the central axis of this EKG, thus giving it its name, twisting of the points, or torsades des points. This can, as I'm sure you can imagine, rapidly degenerate into ventricular fibrillation with this really chaotic firing down here in the ventricles, which of course is deadly. Now let's look very briefly at some of the EKG morphology that we're going to see with some of the more common arrhythmias. I don't expect you to know this for all arrhythmias, but we're going to start with atrial flutter and especially atrial fibrillation, as atrial fibrillation is going to be the most common arrhythmia that all pharmacists across the board will see in their practice. First, with atrial flutter, some things that you may see on an EKG is you may see some of these more peaked, almost like a mountain peak, very angular P waves before each QRS complex. But as this is coming from typically a singular irritable area in the heart, as we talked about with atrial flutter, maybe we have one little area over here in the heart that is then going off and at a particular pace, firing off action potentials down to the AV node. As this is just one of these little spots, we will see a regulated number of P waves before each QRS complex. So as we see in this graph here, we have 1, 2, and then we have our QRS, 1, 2, QRS, 1, 2, QRS. And if we were to measure the R to R interval, the interval between each of these QRS complexes, these are going to be the same. So you're looking, we have equal R to R intervals, we have narrow QRS complexes. This goes back to our EKG basics videos. If we do have cardiac conduction that is going through its normal phases, it will go through the AV node equally through the left and right bundle branches down to depolarize the rest of the ventricles. As this is the normal conduction, both of the ventricles are going to depolarize pretty much simultaneously, thus giving us a nice, narrow, normal QRS complex. I will note this is outside of the scope of most of this lecture, but this is in the absence of a bundle branch block. Of course, you could have some block in one of these branches to cause some spaced out depolarization, but we are not going to go that in depth with our review today. Let's compare and contrast the atrial flutter EKG to the AFib EKG. So one thing you'll probably notice right off the bat here is that the R to R intervals, the interval between each contraction of the ventricles, is going to be drastically different. It's going to be chaotic, and there's not going to be a regular pace to this. So sometimes AFib is referred to as irregularly irregular. So as you see here, really no two, maybe these two slightly, of these intervals are really going to be the same. The other thing you may notice here is that here the P waves, they can be present definitely in AFib, but I would argue more often you'll see either this more jagged line, or sometimes you won't see any line at all indicating atrial depolarization. And the reason for this is there are so many spots up here, as we mentioned, in the atria that are just firing off in such a chaotic fashion. As you see this, if we think about our initial EKG basics videos, these signals are not traveling down towards the recording electrode at all. They are kind of just flying off in any and all directions. So we could see some decreases, some downward deflections if they're traveling kind of up towards the SA node. We could see what we'd expect, a little bit of an upward deflection if they travel this way, and some different things if they're traveling to the sides or curving during their path. So essentially, you'll see either absent or this very jagged, almost sawtooth look to the P waves in atrial fibrillation, and this irregular interval between the QRS complexes. And these, of course, while all of this is very chaotic up in the atria, it does end up going down into the AV node in the absence of anything else weird and conducting normally to the ventricles. So the ventricles, while the depolarization may be fast, it will still be through the normal conduction system, thus giving us a narrow QRS complex. If you remember any of the EKGs, please remember these two and the difference between the two of them, as you will see them in clinical practice. This next EKG example is not anything that I need you to memorize or that you should be memorizing. I just want you to understand this one core concept, and this is a great way to illustrate it. The morphology of the QRS complex is generally dependent on conduction velocity, of course, and a lot of times when you'll see differences in the QRS morphology, it's either due to some sort of drug or some sort of chemical imbalance, or it's due to a difference. This one I want you to remember, a difference in where the arrhythmia is originating and what pathway it is taking in the heart. To illustrate this, we have our AV nodal reentrant tachycardia up here on the top. And if we remember from what we just reviewed, this is when we have some sort of reentry circuit here in the AV node that is firing off down into the ventricles and up into the atria. As this is happening at some very high rates, of course, we can see a loss of the P wave as it's kind of buried in this QRS complex. I know this doesn't look super even, but generally, as this is a reentrant circuit that's running at a constant rate, these intervals will be pretty similar, and they'll be fast. But like we said, because it's firing off into the ventricles and the atria so rapidly, you'll kind of lose that P wave in the QRS complex. The main thing to pay attention, as we mentioned, is this is a very narrow QRS complex, as even though it is a pathological rhythm, it is originating in the AV node, and it is progressing through the normal cardiac conduction system. So we do see it going down the left and right bundle branches, of course, in the absence of a bundle branch block, up the atria, and depolarizing in a fashion that is normal for the atria, or for the ventricles, sorry, to depolarize. On the other hand, with our antidromic AVRT, if you remember, this one was a little bit different. If we remember, antidromic AVRT has this abnormal connection between the atria and the ventricles that allows conduction both ways. I'm particularly choosing antidromic AVRT as in this pathway, the signal coming from the SA node or wherever it's originating in the atria will not pass through the AV node and will instead go down this accessory pathway into the ventricles and start depolarizing in a rather abnormal fashion. So normally, when we have conduction go through the AV node, both ventricles depolarize rather quickly. But in this case, we're actually going to see this take a much longer time, as this has to travel up into the septum, over to the other side of the atria, and just overall take a path that it's not used to taking. It's easy to remember it as, this is not an exact way of looking at it by any means, but if you had a signal coming through here, it's going to take an equal amount of time because it's going to split. Half it go this way, half it's going to go this way. In this pathway, you're actually going to have that signal come all the way down, and you can think of it as taking twice as long. Of course, this is not exactly what's happening, but just as an easier way for you to remember it, it's having to take a much longer pathway doing one ventricle at a time. For this reason, as it's taking a much longer time to depolarize the ventricles, and it's not following normal conduction pathways, this is why we're going to see in antidromic AVRT, we're actually going to see a wide QRS. And this is a concept you can apply to really any arrhythmia that you're looking at. A great place to start, of course, is making sure that you have, if it is sinus rhythm, making sure you're looking for P wave, QRS complex, T wave, everything is oriented how it should be, etc. Another thing that you can get a really good grasp of what might be going on in the heart, or what conduction pathway might be followed in the heart at that moment, is by looking at the width of the QRS complex and looking at that morphology. The last two ventricular arrhythmias that I want to take a look at are monomorphic ventricular or ventricular tachycardia, sorry, and the one that we just reviewed was torsades de pointes. Let's first start with monomorphic VTAC. So if we remember, this was generally due to a single little irritable area down here in the ventricles. And this single little irritable area, whether it be delayed after depolarizations or whether it be a reentry circuit, is firing off signals to the rest of the ventricle. And this can happen at pretty fast rates. So thus, this, of course, is not completely to scale with our other EKGs, but you're going to see some very fast ventricular rates. Something to note on the EKG is you will tend to see an inverted QRS complex. Now, it is very wide, and we'll touch on that as well, but the QRS complex is inverted. Why is that? If you go back to your EKG videos, you're going to understand exactly why this happens. Normally, in lead 2, we have this axis that goes from the negative potential down to the positive reading potential. And of course, this is going to be overlaid over the entire rest of the heart. So up here is the upper right atrium, and down here is the lower left ventricle. And any signal that, of course, any positive action potential that is moving from the negative towards the positive, positives towards positives, are an upward deflection in the EKG. Similarly, a positive depolarization moving, or I should say conversely, positive depolarization moving away from the positive potential will actually be a negative deflection in the EKG. Thus, because these signals are coming from the ventricle itself, we are going to see an inverted QRS complex. In addition, another review of what we've already seen here is, as we saw, when conduction occurs or starts outside of the normal conduction pathway, we're actually going to see a wider QRS complex as it takes longer time to depolarize both of the ventricles, as it's not traveling down from the AV node through the bundle branches to the Purkinje fibers. So we're going to see both an inverted QRS complex as well as a prolonged or a widened QRS complex. And finally, once again, for torsades, we have many of these different areas, and we have many dispersions of refractoriness. So many of these different areas are refractory to different lengths of time, etc. And these are all going to fire in a very chaotic fashion. And this is going to produce this very chaotic and noteworthy EKG here. This is something that's very easy to pick out, this seemingly twisted ribbon per se around the center line on the baseline of the EKG. So we don't need to go into individually what each of these parts of the EKG is, but I want you to recognize that this is what torsades can look like on an EKG. Now let's go very briefly, super generally over how are these types of arrhythmias generally treated. I absolutely do not expect you to know this. The one thing I will expect you to know, I will mention specifically when we get there. So, our general approach to supraventricular tachycardia on a very high level is going to be focused on controlling the ventricular rate. While the atria beating properly is important, controlling ventricular rate is going to stop an arrhythmia from killing a patient. So, generally, most of our therapies are targeted here at the AV node at slowing down conduction through the AV node, thus slowing down the ventricular rate in general. What are some things that could cause this? Well, for some arrhythmias, you could try a vagal maneuver. The general thing to recognize with this is you don't have to know specifically what these are. Generally, squatting or bearing down and other things that increase the intra-abdominal pressure are going to stimulate the vagus nerve or cranial nerve 10, which, as we remember, the vagus nerve does take action at the SA and AV node and particularly is inhibitory at these sites. So it's going to slow the heart rate and slow conduction through the AV node. And overall, as we remember with our supraventricular tachycardias, if they're sending a bunch of signals very quickly to the AV node, we just don't want these to propagate down into the ventricles, creating a very fast rate. So the vagal maneuver will help to block here at the AV node and thus prevent this rapid response in the ventricles. A lot of times, though, the vagal maneuver is not enough, or it's not going to treat the underlying arrhythmia, so we can try one of those antiarrhythmics we mentioned earlier, adenosine. Adenosine is very short-acting, very fast on, very fast off, and very similarly is going to work to block the AV node almost completely to hopefully prevent this rhythm issue from propagating down into the ventricles. Of note, both of these are definitely more effective for things such as the AV nodal reentrant tachycardia, as you're actually stopping this circuit in the AV node itself, but they are slightly less effective for things like atrial flutter or atrial fibrillation, as you're not really affecting these ectopic foci up here in the atria. Besides that, another one that you're going to want to remember, definitely for the treatment of atrial fibrillation and for atrial flutter, is beta blockers. And if your patient doesn't have any sort of contraindications such as heart failure with reduced ejection fraction, you can also use your non-dihydropyridine calcium channel blockers. Very, very similarly to what we said before, these are overall going to help to slow conduction through the AV node, slow the signaling in the SA node, and prevent the ventricle from rapidly responding to these atrial rates. Other than this, the only other thing I want you to really remember, and particularly in terms of AFib, is you do have to check the CHADS-VASc score. This is outside the scope of this lecture, but you can look it up and get a very easy idea of what it is. It essentially just gives you an idea of how hypercoagulable or how easily a patient with atrial fibrillation will form a clot. Of course, with the atria not generally beating as well as they should, they're kind of just shaking in place. It's very easy for the blood that is kind of sitting there stagnant to form a clot. That, of course, can then travel into the ventricle, get pumped out into the bloodstream and up into the brain. So really, atrial fibrillation, we're really worried about stroke in those patients. So with AFib, you're going to want to check their CHADS-VASc score. And then we're going to want to initiate anticoagulation if recommended. Now, while this is a very general treatment approach, the one thing I do want you to remember, and this really goes for any arrhythmia of any sort, these measures are all to be taken if the patient is hemodynamically stable. There's no syncope happening, there's no loss of consciousness, there's no extreme hypotensiveness. If a patient is ever not hemodynamically stable, if they are not stable here, you absolutely, absolutely must cardiovert the patient or defibrillate the patient. Cardioversion or defibrillation is essentially administering a shock of some sort. Here's my little electrical shock to the heart. And this is going to, if it's timed properly, hopefully reset the heart rhythm and have the heart generate a completely new rhythm. So if the patient is unstable, cardiovert them. For a general VTAC treatment or a ventricular tachycardia treatment, this is specifically for regular rhythm VTAC, so with a normal QRS complex. The main thing, again, to remember is if they are unstable, you do cardiovert that patient immediately. If they're unstable, especially with VTAC, this is a nasty, nasty arrhythmia. And as we mentioned, this can really rapidly degenerate into ventricular fibrillation, which will kill your patient. So if your patient is unstable at all, cardiovert them first. Other things that can be tried if your patient is generally stable, they're not doing too poorly, we can try amiodarone, or we could also try procainamide. And I'd refer you back to your previous lectures to look at these. If you remember, amiodarone we talked about does have a lot of side effects, but is, I should say, much lower risk than some of the others in its class for causing torsades. And it generally is used pretty often in current clinical practice. Overall, these two are going to either prolong refractoriness or prolong the conduction, slow the conduction. And you don't need to know exactly what that's doing, but if you remember, most of our pathophysiology for arrhythmias comes into a timing thing. Everything has to be timed almost to the T. So if you're going to mess with either of those, you can help to abolish that arrhythmia. The reason why we're using amiodarone and procainamide, unlike in the last where we were using beta blockers, calcium channel blockers, is that these arrhythmias are really arising down here in the ventricles. The previous ones were up in the atria where they were arising and then propagating to the ventricles. So if we blocked AV nodal conduction, we could help to abolish the arrhythmia. With this regular rhythm VTAC, these are really starting down in the ventricle, so administering a beta blocker or a calcium channel blocker might not be the most efficacious, as you're not really initiating that signal through the AV node. For this reason, amiodarone and procainamide are good options for these patients. Other than this, as we mentioned, this is a very nasty arrhythmia, so you can also consider an automated implantable cardioverter defibrillator. And these devices are really interesting in that it's going to defibrillate the patient. It's going to administer a massive jolt of electricity to try to completely reset the heart rhythm and have the heart restart again and recreate a new proper rhythm. I would refer you to clinical guidance if you're looking for more specifics, or some of the resources that are going to be listed below the video. And finally, to wrap up our general treatment of tachyarrhythmias, we'll look at torsades. So in general, of course, as we mentioned, torsades, if your ventricles are beating like this, you will likely not be doing too well, and you will absolutely need to be cardioverted or defibrillated. So if you're unstable, again, defibrillate. And I say defibrillate here because in these patients with this type of unpredictable rhythm that is in, and sort of chaotic rhythm in torsades, it's going to be very hard for the machine to be able to time up an electrical pulse like a cardioversion in the way that it traditionally would. So generally, an asynchronized large jolt of electricity with defibrillation should help to abolish this arrhythmia. If a patient is stable and they're not doing too bad, the first thing you're going to want to do is discontinue any medications that are prolonging the QTC interval. And as we kind of mentioned before, another cause for this can be hypokalemia. So number 2, we're going to want to correct hypokalemia or low potassium. And as we also mentioned in the other lectures, through mechanisms that I don't expect you to know, hypomagnesemia or low magnesium, not enough magnesium in the bloodstream, can also lead to some of these arrhythmias. So we also want to correct hypomagnesemia. After these steps have been taken, and if the patient is still stable, not doing too poorly, at this point, we're going to administer magnesium. I don't expect you to know all the steps, but the next thing would be if this still does not end up fixing the issue, you can, of course, go back to guidelines to get a better idea of what you would do next. But generally, your next step here would be defibrillation if none of these other steps worked. Sometimes torsades, as we mentioned kind of earlier, can be accompanied by bradycardia or a low heart rate. That is due to the idea that the lower the heart rate, the longer the QT interval. So lower heart rates can actually kind of exacerbate and contribute to torsades development in patients. So in that route, if it is accompanied by bradycardia, you can do rapid pacing via a temporary pacemaker. However, the thing I want you to generally get out of this is magnesium. Definitely remember that. And if they're ever unstable or not improving, defibrillate. And finally, to wrap everything out, let's do a very, very brief review of bradyarrhythmias. So as we know, normal heart rate is 60 to 100 beats per minute. So a bradyarrhythmia is something that is less than 60 beats per minute. This can be due to two main causes. The two that I want you to remember are automaticity. And this, we want to think of cranial nerve 10, as we've talked about, the vagus nerve. And the second one is a heart block. And there are multiple different types of this, but this is generally some sort of issue with the AV node. Some first-degree heart blocks, as we'll talk about, there are multiple different types. First degree can be completely normal, nothing to worry about. Some other ones, like a third-degree heart block, can be very, very dangerous. So let's go take a look. I've already reviewed many, many times on how vagal stimulation or increasing vagal tone is going to inhibit the SA and AV node, and thus slow conduction, slow heart rate. So let's take a little bit of a deeper look at heart blocks, the easy telltale features on EKGs as to which type of heart block is there, and then again, very, very general treatment algorithm. So the first thing to remember is these types of heart blocks are problems here in the AV node. First one we're going to talk about here is a first-degree heart block. Now, this is generally, or it can be a benign thing, something that doesn't really matter that much for patients, but it's a dysfunction in the AV node wherein the PR interval, or the time between the beginning of atrial depolarization and the beginning of ventricular depolarization, this time when the action potential is essentially held in the AV node, is prolonged. And when we talked about how long this P to R interval should be, as we know from here to here, this is the PR interval. Normal was anywhere up to 200 milliseconds or 0.2 seconds. So here we just have a prolonged PR interval of greater than 200 milliseconds. And this will be the same throughout the EKG. So this is a very easy one to identify. Many times it can be completely benign and not something you have to worry too much about. Second-degree heart block is also referred to as a Mobitz type 1. And as you see here, we have something a little bit different, something a little weird, where, as you'll see here, we first have a P wave, as we would normally expect, atrial depolarization. Pretty soon afterward, we have a narrow QRS complex, and then a T wave. So this first little bit looks okay. The P to R interval could even be normal in this first one, or close to normal, I should say. Then we move on to the second one. Now we have a P wave again, and then a much longer time, progressively longer time, until the QRS complex starts. But we have a little bit of a longer PR interval. And then, of course, we have our QRS complex, T wave. Then we have a P wave, and then here we have a completely dropped QRS complex. We have one action potential that did not propagate from the atria to the ventricle. It was completely blocked here in the AV node. So that is something that is very stereotypical or typical of a second-degree heart block, which is also called Mobitz type 1, the first of the two types. And here we'll review our last two types of heart block. First one here is second-degree heart block, and this is Mobitz type 2, so a little bit different from Mobitz type 1. In this patient, unlike the Mobitz type 1, where we saw progressively longer and longer P to R intervals until a dropped QRS is observed, we're going to actually see a normal P to R interval, and it's going to be pretty much the same all the way through. So as we see, normal PR interval. The thing that is not normal is here we're going to start to see completely randomly dropped QRS complexes. So here we have a P wave, the atria depolarize, moves to the AV node, ventricles depolarize, T wave, P wave, and we have a completely dropped QRS. Then we have a P wave, QRS, T wave, P wave, QRS. Maybe after this we just drop another random one. There can be either no association with this at all, with just randomly dropping QRSs all over the place, or there are some versions of this Mobitz type 2, almost a subclass, that maybe you'll have two beats or two atrial depolarizations, and then you'll finally have a QRS complex. Then two atrial depolarizations, then a QRS complex. These are both different versions of second-degree heart block Mobitz type 2. Finally, we have our third-degree heart block, and here we're going to see some very, very weird things. The first thing that you'll probably notice is there are completely random amounts of P waves between the different QRS complexes. In addition to that, we're seeing this really, really strange wide QRS, which we have not seen with any of the other types of heart blocks. What does this mean overall? The first thing is there is no association here. There's no rhyme or reason between atrial depolarization and ventricular depolarization. As such, the AV or the atria is completely dissociated from the ventricles. They are beating completely independently. So there will be a completely random number of P waves between each QRS complex. Something that's interesting to note here is this super wide QRS complex. Why would this be? We learned that this happens when something originates outside of the normal conduction system. What's happening in a third-degree heart block is that we are completely blocking this AV node. We have signals coming from the SA node down to the AV node, how they normally do through the atria, and the AV node is not propagating any of those signals. It is just a complete wall at this point that the signal can't get across. So what's happening? Essentially, the ventricles down here are depolarizing completely independently of the atria. They are depolarizing on their own as they have lost the override of the SA node, essentially. So now they take over their own pacemaker potential and start beating at their own rate. So you'll generally see the rate here of the atrial depolarizations. This is approximately the SA node rate. And here the ventricle depolarization is going to be approximately the AV node depolarization rate, intrinsic rate. The really nice thing about the general treatment of bradyarrhythmias is that if the patient is stable, you just have to monitor. You don't have to worry about doing too much. Stability, of course, is as long as the patient does not have any of the following symptoms. That can include shock, chest pain, confusion, altered mental status, low blood pressure, or heart failure. If your patient is not experiencing any of those, just keep a watch on them. Get some EKGs every once in a while. Make sure that they're doing all right. If the patient is unstable, experiencing any of these signs, your first treatment is going to be atropine. And of course, there are more treatment algorithms available online. But if atropine fails, then we can go to pacing. And this is transcutaneous, otherwise not an implantable pacing device. Or other than this, we can try our direct agonists, direct things to increase heart rate, increase conduction through the AV node, and this is epinephrine or dopamine. Like I mentioned, very simple for the treatment. I don't need you to know much for bradyarrhythmias. The main thing is if they're stable, monitor; unstable, atropine, pacing, epi, or dopamine. Nice and simple. I just wanted to wrap up this fourth and final lecture by saying thank you to all of you for sticking through and watching all of these videos on just a review of cardiac arrhythmias, and especially things that are important to remember in pharmacy when looking at or understanding cardiac arrhythmias. I know it's kind of a lot of information. I tried to pare it down to what I thought was necessary. For drugs, we talked a lot about side effects. We did not talk dosing. We did not talk ultra specifics of pathophysiology, but I hope that this gives all of you future or current clinicians, if you're interested in watching, a better understanding just generally what causes cardiac arrhythmias, how do you read an EKG, how overall are they treated, what are the general concepts. But thank you once again. This was both a project that I was doing and a passion project personally. I am personally very invested in cardiology, everything. And one thing I had not taken a deeper dive into was arrhythmias. And this has given me a fantastic opportunity to take a much, much more in-depth dive into arrhythmias and learn more about it in order to teach all of you. So thank you so much for helping this become a reality. And if you would like to, we do have a team-based activity. You can complete it alone or ideally in a team, just some case-based application on some of these arrhythmias. And then we do have a very short quiz, just 10 questions, some very general concepts on arrhythmias, and you can see how you do. But with that said, I will let everybody go. Thank you once again.